welcome back to A Voice and Beyond. We have Dr. Shannon Coates. How are you, Shannon?
I'm very well, thank you, Dr. Marissa.
Oh, we're going to be
Return
formal.
the doctors.
Oh, okay. From one doctor
We
to
don't.
another.
That's right.
Look, I am
Very well.
so grateful to have you here today. And we're going to talk about a really important topic. And it's a topic that affects all of us in one way or another. And we're going to talk about how it impacts us in the singing teaching studio. So, Shannon, you're an educator, you're an international presenter on vocal pedagogy, you're the creator of the Vocal Instrument 101 online course and VoicePed UnDegree. And we see you pop up a lot on social, and I love watching you on social. You're just so cool.
In there. No, thank you.
You are. You just have such a way about you. I just love it. But before we get started, I think it's really important that we put a disclaimer out there because this is a great responsibility that you're taking on, talking about this topic on neurodivergencies. So the disclaimer is that you're not a medical doctor or a healthcare practitioner. And we are going to talk about concepts around neurodivergence. And you're going to respond to the questions that I'll be asking you based on your own lived experiences with neurodivergence, your training and work in this area, as well as the work and the words of those from the neurodivergent community. Now, our focus and our intention with this interview, because once again, I feel like we have to be very clear with where we're heading with all of this, is to build and advocate for inclusivity, support strategies to help develop an understanding of individual student needs, and to normalize and to take away the stigma attached to neurodivergence. So that is the disclaimer and our intention here with this interview. So, and
Beautiful.
I know that you have done a lot of work in this area. I know you have been a spokesperson in this area. You have waved the flag in this area. So before we start, it's another before we start.
Yeah.
There's a lot of before we start and before. When it comes to neurodivergences, how should we refer to them? Do we refer to them as issues, disorders, problems? What is the language that we should be using?
Yeah, it's such a good question. And I must say also a real conversation within the neurodivergent community, especially within the autistic community, and also within the community of folks who have multiple neurodivergences. And I'm not going to say the overwhelming consensus. I'm going to say the folks who are doing the education around the topic of neurodiversity affirming culture, neurodiversity movement, and the folks who are doing that kind of work who are neurodivergent. I am neurodivergent. I'm an ADHD person, so that's a form of neurodivergence. The folks who are doing that education, we are advocating for an understanding that these differences in the brain are literally just that. They are differences in the brain, differences in ways of processing, differences in ways of gathering information, and in ways of then bringing information out. So because they are differences, and because these are things that are not measured, we think of the norm, or I'm putting that big quotes there, the what we have thought of as the norm has become the medical norm as well. So that has become the quote healthy or the normal. And overwhelmingly, that tends to be the folks who have, who are neurotypical. That's the other side of
Yes.
neurodivergent. So
Yes.
neurotypical, who are able-bodied, who are white, who are cis, all of those quote norms at some point were medicalized as well as being the normal thing. And so for a very long time, and still to this day in the DSM, for example, we have names such as autism spectrum disorder, attention deficit hyperactivity disorder,
Yes.
syndrome, all of those terms that come from the medical field that are using or saying this compared to what we say is normal, and what we say is quote ordered. These are all disordered. And so the neurodiversity movement, the neurodiversity affirming movement, the folks in the neurodivergent community, the conversation is around, this is not disorder, but different. So this is perhaps atypical. There's lots of conversation around what the actual language is that we want to use.
Yes.
But perhaps atypical, divergent, all of those sorts of things. So then we often then hear people say, describe themselves as being, for example, I describe myself as being an ADHDer or an autistic person, or, lots of different words that describe the thing without saying it's disordered or without referring to the fact that it's a disorder.
Yes.
So when we talk about the language and the way we describe, as soon as I hear people saying this is, these problems, these challenges, these disorders, all of those kinds of languages or disabilities, especially if they're outside of the community, that speaks to me of a medical model and of a comparison from what I think is normal, big quotes again, to what is abnormal or unhealthy. So healthy to unhealthy, or ordered to disordered. And that is not the model that has been useful for the vast majority of the neurodivergent community. So, and that is a whole part of the movement, the neurodiversity movement and neurodiversity affirming movement, is to change that conceptualization. And as you said in the intro, to normalize, remove stigma. Big part of the disability part, put that in quotes as well, around, for example, being ADHD, being autistic, etc., is not necessarily that it is a disability or an inherent disability. It is a disability because society is not set up to support these ways of being in the world. And so then it becomes a disability because it is cultural, it is society, it is because society is not set up. These things become, to bring it to this voice studio, these things become a disability or a challenge in the voice studio because the voice studio is not set up. The teachers, we are not set up. We do not understand neurodiversity affirming voice pedagogy, for example, and we are not set up to support and affirm those things, those ways of being in the world, and therefore they are then a disability.
And it was interesting, I was talking to you prior to this interview that I had been listening to a podcast last night and again this morning that accidentally came up while I was listening.
What do you know?
It just went from one podcast episode to the next, and it was Dr. Chris Palmer from the McLean Hospital in Boston, who's been doing 20 years of research as a psychiatrist into neurodivergence. And he was saying that in the medical field, they are still referred to as mental illness, which is, I mean, that is a really strong, harsh label. But moving on, are there different categories that fall under the umbrella of neurodivergence?
Well, it depends on who you ask, of course. neurodivergent activists, folks who are at the forefront, who are part of the community, and who are at the forefront of education around this topic in the broader world, talk about many of the things that we might consider, anything that is atypical to what we would consider the norm as being neurodivergence, or falling under, excuse me, that neurodivergent umbrella. So we talked about ADHD and autism, which are the two sort of ones that everybody kind of knows about, but lots of different learning differences. Dyslexia, for example, is considered a neurodivergence because it is a processing difference. There's the way that we're processing things is atypical, if you will. And lots of things, Tourette's, OCD, lots of those other brain differences may be considered part. And then there are also there's also discussion around acquired, if you will, neurodivergences. So some of them are considered innate. In other words, this is the way my brain was when I was born. And that's part of the reason probably that a lot of these neurodivergences tend to end up in families. There's a big joke in the community around, as your kid is getting a diagnosis, your partner and you are looking at each other side-eyed in the office going, that sounds very familiar.
Yes.
I wonder where that came from.
Well, it's interesting because when I was listening to this Mel Robbins interview with Dr. Chris Palmer, and many of the listeners here may follow Mel Robbins. She's an amazing speaker and thought leader. She was diagnosed with ADHD, dyslexia, and dysgraphia.
Dysgraphia, yeah.
Yeah. Now,
which often goes with dyslexia.
Yes. In her late 40s, she was sitting there with her son, and her son was being diagnosed because he was always told that he was like the naughty kid. He was the one that the information wouldn't stick. He was the one that couldn't sit still. So he was labeled the naughty child. So a doctor suggested that he undergoes testing for ADHD. And while she was there, she was thinking, wow, a lot of this sounds like me. And I've heard of other people that this has happened to as well. So you're talking about this genetic thing, but to take this another step further, because what I didn't realize was that anxiety and mood disorders also fall under the umbrella of neurodivergent. And
acquired neurodivergence. Yes.
In our family, there is a history of depression. There is also a history of anxiety and a lot of that as well. So I've seen that. And it's not only myself, my mother, myself, my kids have suffered with that from time to time, but also cousins.
Yep. Yeah. I mean, it's complicated, right? And can you ever say that that thing is innate only and that thing is only acquired? I'm not sure that you could ever say that. I'm not sure. It's far more complex than that, of course. And there's always the element of trauma. There's always the element of our experiences. There's also always the element of nurture, and what kind of nurture, and how we grew up, and how those things were dealt with, if you will, how we were supported as kids. There are always all of those aspects. And trauma responses can look very similar, especially to autistic responses. So the behavioral responses can look very similar from, someone who is responding out of trauma or unhealed trauma or undealt with trauma, and someone who is responding because of the way they process. So those are two different reasons to respond. And also lots and lots of neurodivergent folks are also dealing with trauma because of being raised in a society. Well, I mean, it's completely
like this being on this treadmill, and you just can't get off it because one exacerbates the other.
Or yes, exasperates or compliments sometimes. But
Yes.
I mean, the point
Yes.
remains that there is, so one of the things that comes up quite a bit is, and we were talking about this actually earlier, is this idea that, well, everybody's a little bit neurodivergent these days, aren't they? I know, like everybody I know has something that's
Mm-hmm.
happening, right?
Mm-hmm.
So, like,
Mm-hmm.
is this a thing where everybody's just a little bit? And that is something that is, I mean, there's both the sort of overall, well, everybody's a little bit neurodivergent, which is a little bit flippant and a little bit like, I'm just observing all of these things now. And then the other question of like, why is there such a high level of a diagnosis now? But the idea that everybody's a little bit neurodivergent, let me say this, the for myself, for example, the character, the traits that I know that are part of my ADHD and part of the way that I function in the world in terms of moving through this ADHD, and moving with ADHD in this world. Um, Everyone at some point forgets their keys. Everyone at some point, goes off topic in a conversation. Everyone at some point procrastinates. Everyone at some point doesn't, like there are all of those things. But
Yes.
when it is pervasive in your behavior and when it is actually impacting the quality of your life,
Mm-hmm.
that is a different thing. So that
Mm-hmm.
is, yes, there are traits, there are things that happen with an ADHD brain that everyone will experience at some point in their lives. You're overwhelmed, leave you forget to pick up your kid from school. Great. Whatever. Like there are things, right? But
Yes.
pervasive, consistent, I cannot get on top of this. I cannot change this in my life no matter how hard I try. That's a completely different thing from
Mm.
like, so these are
Mm-hmm.
the when we, and also, when we look around and we say, look, everybody's a little OCD. No, no, we are not. OCD is a completely different thing
Yes.
from, even from
Yes.
generalized anxiety, right?
Yes.
And
Yes.
everyone's a little autistic, we all get a little autistic. Well, no, no, you don't. No, you don't.
Right.
It is not everyone's a little. There absolutely are diagnostic and, there are absolutely diagnostic traits. There are traits and characteristics and behaviors that we can look at and say, oh yes, that is pervasive, that is happening, this is a thing that is happening,
Mm.
as opposed to everyone's a little bit. The
Yes.
other side of that coin is like, why do we have such an increase, or it seems to be anyway, such an increase in, diagnosis, medication, etc. Um, and we talked about a little bit about that earlier as well. But there are lots of ideas around why. Certainly, there are the folks out there who say, well, everyone is just self-diagnosing because of stupid TikTok, and this is
Mm.
really harmful because everybody shouldn't be self-diagnosing, and there shouldn't be, and no one should be getting medication if they don't need it, and et cetera, et cetera. So there is that side of things where there are folks who view this as harmful, as something that should not be happening, this increase in diagnoses and this increase in, and perhaps this increase in medication and medicating. However, the wonderful thing about the fact that online platforms have given neurodivergent people a voice is that we have community. We no longer have people in their, like myself, thinking, well, I'm just a lazy undisciplined person
Or
who
I'm dumb.
procrastinates,
I just
or I'm
feel,
dumb.
yeah, because I can't retain information, or I'm
Yes,
reading
yes,
this on this page, but it's just not
yep,
computing. I've read it 20 times. Why am I not
absolutely.
understanding it?
Yes. Or I must be dumb because I can't read, and
Mm,
then you look and see, oh, my favorite actor is dyslexic and I am too. Oh,
mm-hmm,
okay. They
mm-hmm,
made it. Maybe
mm-hmm,
I can too, like
mm,
there is, and also, or you spend your entire life thinking you're never going to be able to make friends and the whole world is just a very horrible place with people who are not honest and cannot be honest with you and can't accept you as you are, and you have to just try your hardest to fit in somehow. And then
yes.
you meet an online community of autistic people who communicate in the same way that you do and who are very happy to communicate in that way with you and accept
Mm,
you, and you go, oh, there's the community I was looking
yes.
for.
Yes.
So I think there's a combination here of certainly far more information, of course, available, so that we are now able to say, oh, that's a thing. I didn't know that was a thing. Community where people are saying, hey, this ADHD med was really useful for me just to help me find myself and get in focus and be able to stay on track. There's lots of stats out there about, especially folks who we perceive to be female and or who are socialized female, having I can't remember the exact numbers now. I'm unfortunately, but it's somewhere in the range of, by the time an adult woman gets an ADHD diagnosis, for example, they will have seen, 6 or 7 medical professionals,
Right.
or
Wow.
they will have been on, I can't remember how many it is, but it's maybe 3 to 5 different antidepressants
Mm-hmm.
or mental illness medications for mental illness,
Yes.
and then they get an ADHD diagnosis and they're like, oh, look, if I was just taking Vyvanse all along, I would have been absolutely fine. What do
Mm-hmm.
you know?
Mm-hmm.
So, yes, so there is this increase in, like, certainly this increase in the recognition, the diagnosis, and all that. But
Yes.
I'm not worried
Yes. Well,
at all.
here in Australia, the
Mhm.
stats were that prior to
Right.
COVID, there were 1.4 million prescriptions given to
Mhm.
186,000 people. So that was in 2018. And in 2022, there were 3.2 million prescriptions given to 414,000 people. Now, that was here in Australia alone. And
Yeah.
in the Singing Voice studio, I feel that there's been a great number of students who have returned from COVID
Mm.
who are suffering with anxiety,
Mhm.
depression. A
Mhm.
lot of these students are being medicated or seeing a
Yeah.
psychologist or a counselor. Some students have even tried to self-harm. There
Yeah.
have been multiple students diagnosed with ADHD. So you talk about that situational cause or that
Mhm.
life event or that trauma.
Mhm.
And I feel that maybe COVID has created a greater problem, or maybe the problem, or that was always there, that underlying problem was always there, and maybe COVID and that isolation or the trauma or the fear or the that whatever we were going through
Mhm.
has brought it to the fore. Who We don't know, do
Who
we?
knows? Yes. Who knows? Who
Yeah,
knows?
yeah,
And I mean, time may tell. Who knows what the stats are?
yeah.
Time may tell.
So why do you do this work? Because I know that not only you have ADHD, but also your children are
Mhm.
neurodivergent. So do you
Mhm.
want to
Mhm. Mhm.
share a little bit
Mhm.
about your children and their journey, and you
Sure.
as their mum?
Yes, I am their mom.
Yeah, well, I hope
I
so.
mean, yes, I am. Yes, I am. I mean, the reason that I stepped into this kind of educational role with this issue in particular. It started because I was looking at so many of the the accommodations, I'll say accommodations, but so many of the accommodations and so many of the supports that my children were able to get in school and in the educational system, and many things that I hadn't thought about before, as well as much of the therapy that they've had neurodiversity affirming therapists since they were since diagnosis, actually. So
how old, sorry, so how were
mhm.
how did they come to be diagnosed?
So my my younger child, when he was in junior kindergarten, my older child is 2 years older, so when he was in junior kindergarten, the teacher said, "It's very strange. He knows his alphabet, but there's something going on there, and I wonder, if possible, I wonder if you might just see what's going on there." So that, or maybe it was in senior kindergarten, I can't remember now, but at that point, yeah, it was senior kindergarten.
So what age are we talking? About 4 or 5?
5.
Okay.
5. Yeah. So the summer between senior kindergarten and grade 1, we had a psychoeducational assessment done. That's what they're called here, which is outside of the school with a private therapist. So with a private psychiatrist, we paid privately for that. And when we had that done, it was so revelatory and so, it was such good information that we were like, let's get our daughters done as well. We did not, and so they both had those done. And at that time, Asperger was still part of the DSM. It is no longer. So Asperger's is no longer a diagnosis. It is, everything falls under autism now. And so at that time, so they were like 5 and 7, maybe. And the therapist said, there are some markers for Asperger's here. And again, this is going back like nearly 20 years. So this is going back a little while. So there are some, or 15 years. There are markers for Asperger's here. But here are some of the other learning difficulties that are the learning challenges. Dyslexia, for example, they're processing things. Dyscalculia, which is numbers. It's like dysgraphia or like dyslexia, but numbers. A bunch of different processing things. So that was very good information, and we would never have had our daughter tested if it hadn't been for how good the information was with our son. And they were never tested because they were behavioral issues, so they would have absolutely fallen through the cracks if that kindergarten teacher hadn't said something.
Wow, how lucky!
So, yeah.
So he wasn't the naughty child that couldn't
Absolutely
sit
not.
still in the corner.
Absolutely not. Part of the reason that the only way that he could figure out which letter he was supposed to be using was if he went through the entire alphabet song. So if you said, which letter is this? And you held up an E, he would go, C, D, E. It's an E. He could not. And if you asked him to write an E, he had to go through in his head the alphabet song in order to figure out. He knew his name because I had made a song for him, not thinking that this would be a way for him to but he knew how to spell his name because I had made up a whole song for his name, and just because it was fun. And so he knew how to spell his name. And so the kindergarten teacher noticed that he is processing something differently here. He is not able to just name a letter. He's not able to just there's some processing going on here that is different. And also he's not picking up the writing. She noticed that as well, that he really wasn't picking up writing in the way that he, that she thought was appropriate for his age. So Yeah, I mean, we had a full psychoeducational assessment done. Then again, it was probably 2 years later, maybe 3 years later. And at that time, then they had a full diagnosis of autism and ADHD for both of them, dyslexia for both of them, and lots of different processing challenges.
And a
So
lot of
those,
and a lot of those do go hand in hand.
absolutely,
It's
yes.
not that it's one diagnosis exclusively. It's quite often
Yeah.
there's multiple.
Yes, it is. We often see clustering, they call it, a
Okay.
clustering of neurodivergences.
Mm-hmm.
So,
Yes.
which very interestingly, it is actually quite recent that a dual diagnosis of ADHD and autism was actually possible. Un Until quite recently, I can't remember the actual day now, the actual year, but it's quite recent that they actually gave out dual diagnosis of
Yes.
autism and ADHD. But anyway, that so yes, so they have those diagnoses, and as I was going through those, as we were going through all of these supports and therapies and different kinds of uh, you know, ways of supporting them, especially in the educational system, I started to see some of the things that I thought, why am I not teaching this way? Like, why am I not doing this in my voice studio?
What's an example of that?
So an example would be behavioral. So, or recognizing behaviors, for example. So the teachers, one of the things that a therapist might say that was shocking for us was, well, you are asking them to do something that they actually do not know how to do, and you're expecting something that is beyond what they are able to process right now.
Wow.
And then you are giving them consequences for not doing it. And so then they, in return, are lying to you. They don't want to, but they're lying to you because they're trying so hard to do the thing that you want them to do.
So they were covering up.
They're covering up, absolutely. So then I start to say, okay, in the studio, when I am expecting someone to do something, but I haven't given them options for them to figure it out, and then I am penalizing them, what am I expecting is going to happen? Of course, they're going to be perhaps defiant. Of course, they're going to be, the Joker in the studio to get out of it by like just being the clown, and we laugh together, and oh, it's fine. Of course, so of course, there's going to be some kind of. We do this with parents as well when we have sort of punitive cancellation policies, where like there's lots of
I totally get it. Yes, I totally get it.
Of course, people will then say, no, my kid is really sick and can't come in today, when in fact they just forgot and scheduled something else, and now, I mean, of course they're going to lie to you about it.
Or they are so scared to come in for fear of failure, because we are setting them up for failure. So we're essentially, if we're teaching from a place of this is right, this is wrong, that's good, that's bad.
That's bad.
That student is not going to want to come in, because they're going to they're already in that hypervigilant state. It's going to make that problem even bigger for them. And
100%.
they're not going to want to come in. And if they do, I know there's behaviors too, that a student will talk and talk and talk and talk to get out of singing.
Of course.
They're doing everything they can to avoid actually singing. For fear of judgment.
Yes. And is it because they're a bad person, or they're a deviant person, or they're no, of course it is not. However, that hits us hard, right? Like we take that personally sometimes. We're like, well, they're just, these students, like we take that personally often
Yeah. Yes.
rather than looking at the behavior as just a communication of something being
Mm-hmm.
wrong. Like it's
Mm-hmm.
just, that's all it is. So
Mm-hmm.
something else we expect, we expect kids, teenagers, kids who have been at school all day, and this is especially prevalent for adolescent folks who are going through hormonal changes, but also an autistic kid, for example, who has been masking all day long at school and who has been working very hard all day long to stay focused, to keep listening, to especially if they have some auditory processing differences, which is very common. Again, that is a very common, that's also children developing. I mean, auditory processing is a thing that we develop as we get older. Like there's
Yes.
a normal
Yeah.
developmental part to that, but
Mm-hmm.
also that can be a neurodivergent trait as well, is to have
Yes.
some auditory processing differences. And so they've been working their whole day. Perhaps the lights have been buzzing very strongly. Perhaps it's hot outside. Perhaps their toe hurts, whatever. Maybe they feel slightly sick to their stomach. They've been working their whole day to stay good, to be a good student. And
Mm-hmm.
then they come to their voice lesson at 4 o'clock after school. And we expect them to stand. We expect them to look us straight in the eye. We expect them to answer. That we expect them to listen. We expect them to display all these behavioral traits that we consider respectful or that we
Mm-hmm.
need them to do in order to
Mm-hmm.
show us that they are learning.
Mm-hmm.
This is completely not
Yes.
useful.
And when you think that with singing, we're activating every part
Yes.
of the brain. So they've already been in a situation where they've had to use the brain
Yeah.
in a way that probably doesn't come naturally for them.
Mhm.
And then
Mhm.
we're asking them to come to the singing lesson and fire up everything, fire up
Yeah.
all cylinders.
Yeah.
That's a
Yeah.
lot. That is a lot.
It's a lot. And that's the main thing, right? I think when we think about, okay, but how will I know how to treat a neurodivergent student? Like, how will I know if there's something going on there that I should be supporting, or I should be affirming, or changing in order to be able to support them? And the main thing is this: whenever you feel triggered by a behavior, you need to get curious about that. So if you've got a
Mm,
singer who comes in and you feel is not taking their lessons seriously because all they want to do is sit on the couch and not stand, take a second to think about that. Do you think they're not
yes.
taking their lessons seriously? Or do you think maybe they have stood all day? Maybe their body is not able to function right now. Maybe they can do some lip trills while lying on your couch. Is it
Mm,
really, do they
mm,
really need to stand up in order to show you that they're paying
mm.
attention and they're learning? No, they do
Yes,
not.
yes, yes.
They absolutely do
Yes,
not.
yes. We have to be accommodating. I know with many of
Mhm,
my students, when I feel that they're not on form for whatever
mhm.
reason, I just get them to lie on the ground and
Why
close their
not?
eyes and to
Mhm,
breathe and to do
mhm,
some like accent breath work where
mhm,
they're using voiced and unvoiced fricatives in
mhm.
a rhythmic pattern, and
Yep.
do that for 5 minutes
Mhm.
and I always say, let's not judge the sound. Let's
Yeah.
just focus on the breath. There is no
Mhm.
judgment here. There is no right or wrong. Let's just focus on the movement of the abdominals. Let's just focus on the breath. Let's just
See what
pretend
surprised.
we're in bed. It's those final moments before you're
Mhm,
drifting off to sleep.
mhm.
And
Yeah.
and students come out of that and they say, wow, I feel amazing. And then
Yeah.
if they're fatiguing, I have an ottoman in my private studio and I have chairs in my studio at the
Mhm.
conservatorium. And I say, you know what? We can sit.
Yeah.
And I find though sometimes when a student is really activated, or just having them sit just seems to calm everything down, you know, say, but everything that you're doing, you do when you stand, we just need to make sure we do when we're sitting. We just want the chest cavity to be open, just relax our shoulders,
do whatever you want.
you know, do whatever you want. Yeah. So I've become far more accommodating by listening to the students in that moment on a given day, and also not putting limitations or expectations. I've taken that away.
Right.
So I've done the work on myself as a teacher to get to that point.
I think you can go, I think the next steps even further in what you're saying as well is, first of all, to normalize. So whenever we find ourselves offering what we might think of as an accommodation, or, you know, I see you're fatigued, let's take a seat. Does it feel like now would be a great time to just kind of lie down and do a little bit of grounding and maybe some breathing or something like that? Would you like to walk? Would you like to pace while you're singing today?
Yes.
Would you like, what kind of movements would you like? Like,
yes,
all of those kinds of questions. As soon as those things are coming up as an accommodation for a student in a situation, I think the next step is to start to take notes and normalize those things as options. So now it's not me who has to notice when you aren't feeling, when you need something. It's me saying, hey, guess what? In this studio, everyone sits whenever they feel like they want to. Everyone lies down if and when they feel like they want to. Everyone grabs a fidget toy if and when they feel like they want to. Everyone can move the light switch, the dimmer, up and down if and when they feel like they want to. Anybody can do whatever they need to do, because I am now going to normalize the fact that everyone has options. And also, you don't just take the option because I happen to notice that you needed it, but you get to start to understand what you need to be able to sing and to be able to do your best work in this time.
Yes.
So, and then you get to ask for it. You don't even have to. So then those things become not even accommodations anymore. They become, now I'm affirming your choice, normalizing your choice, and normalizing you having agency over your own body and noticing what's happening in your own body, right?
Yes.
You have the agency.
Yes.
So of course, at the beginning, that may be something where we're saying, would it be useful for you to like sit on the chair for the rest of the lesson? Would that be useful? Great. And so now I might even send an email out to the entire studio and say, hey, I just want to make sure that everybody knows that I have this chair in my studio for a reason.
Wow.
This isn't something that you have to like, it just occurred to me that maybe not everyone knows that this chair is here for a reason. It's not just a decoration. It's because I want you to be able to take advantage of it and sit if and when you need to. I trust you to know your body.